Hi, today we're going to talk a little bit about how trauma and grief are interconnected. And so we'll do a portion of this PowerPoint here on trauma, choice, and resilience. And to help you understand a little bit about how I came to do the work of trauma that I do, I wanted to walk you through my experiences. When I was about 17, I was living in Chicago and I was working in a therapeutic school. And we were quite a unique model. It's one of the only schools of its type at that point in time that was focused on providing services to children with severe learning disabilities. And we were just beginning to understand the spectrum of autism diagnoses. And so I saw a lot of children that were severely autistic. I had one little boy that I was working with who had elective mutism. He had experienced trauma in his home and had stopped talking. And during that time, he taught himself how to read. So he had pretty high functioning in terms of intellectual abilities, but socially and emotionally, he was unable to function as a result of trauma. So I was learning a lot in those early days, and it helped me as I moved into becoming a teacher. I was initially an elementary school teacher, taught third grade, fifth grade, junior high, and special ed. And all of those early experiences in learning about brain function and severe disabilities was very helpful because in those days we were seeing a lot of children diagnosed with ADD and ADHD, and I'm still seeing quite a bit of that, quite frankly. But what was happening is that, they were missing some of the other things that were going on with these children, like, perhaps learning disabilities that would explain the attention deficit that was happening. Um, and so, people were referring and looking for medications to treat, but maybe not going as deep as they needed to, and to understand what else might be an explanation as to why a child would present with ADD or ADHD, which could be trauma-based. Maybe there was violence in the home, or maybe there was an addiction problem within the home, or something else that would explain it. The other thing we referred to it back in those days was minimal brain damage, which was not a very, I don't know, perhaps nice diagnosis to label a child with. And it's because we saw it as maybe related to birth trauma. So, I continued to have an interest in the brain-based learning approach and the brain-behavior relationship. And after working with children, I started to work in gerontology, and I worked in all different kinds of environments. I worked with the elderly in retirement homes, so they were independent living. And then I worked in assisted living and the gradual step-down programs where people were needing some assistance to total assistance and living in lockdown units that were psychiatric based, in some cases memory and dementia programs. And so I saw all the different forms of dementia in these situations, and I continued to learn about brain behavior relationships. And so, you get to have an understanding as you work in these environments and you work with enough people of how trauma can be a thread that runs through all of these different diagnoses. And, I also got to experience firsthand the impact to families and the grieving process that they go through. Of course, it's not the same step approach that, has been taught necessarily through Kubler-Ross's model. I know she never intended it to be so didactic in the way that it came to be understood. And it was a model that was helpful, for us to understand that, grief is a dynamic process, and so whenever you have trauma and loss, there's going to be grief. And when you're talking about, in the case of children or family members that lose functioning, it'll be a complicated bereavement process. And we didn't really understand that until recent years. And by recent, I mean perhaps the last 20, 25 years, we started to really talk about that more. And so from there, after I was, working in those environments, I started to work with Vietnam era veterans. And I'm forever grateful for the work that I got to do with the veterans in the VA system, because they really contributed what we now understand about trauma. Because at that point in time, we were still diagnosing trauma as if it only occurred in soldiers and it only occurred in life-threatening situations. And those of us working in the field were experiencing something different, because we were seeing clients who had a history of molest or had been in homes where domestic violence was occurring. And so there was no other word to label it other than trauma. And so we were using the PTSD diagnosis kind of off label, if you will, because it didn't really fit the criterion as it was described in the DSM at that particular point in time. But we were seeing a lot of the same symptoms that you see in veterans, with PTSD. It's the hypervigilance, and some of the other related anxiety and depression. So let's look at that for a minute and just kind of review and remind ourselves how is trauma defined. It involves a persistent avoidance and related to thoughts and feelings or conversations associated with trauma. And, anything that's going to arouse the recollection of the trauma is avoided. Sometimes people will have memory gaps, and so they don't recall certain aspects of the trauma, or they might have diminished interest or depression related to it. They can experience dissociation or detachment of feelings, inability to label their feelings or recognize their feelings, and thus a restricted range of emotions. And they feel as if there isn't really a future for them, that life has ended when whatever the event was that caused them to experience trauma occurred. So in terms of the DSM, PTSD is about the exposure to an actual event that was threatening to life or of serious injury. And it had to involve some kind of intense fear, hopelessness, or horror. And it is personally or persistently re-experienced. And there would be distressing recollections, recurrent dreams, flashbacks, and internal and external cues that are both psychological and physiological. And so you could see this kind of experience happening not just with veterans. It happens, of course, in other types of situations. And so it seemed restrictive to use that label only in the context of war. And so we began to have a much broader understanding of trauma and how we treat trauma as a result of that. So, I learned a lot in working in gerontology, and so I continue to have this interest in, brain-based functioning and, how it appears in terms of various diagnoses. And so from there, after working with geriatric patients, working with veterans, I also started to work in neuropsych. And I was working in a lockdown unit with individuals who had sustained traumatic brain injury. And in these cases, these have been individuals who were highly functional, prior to sustaining this injury. And, they had, in some cases, been in a coma for perhaps as long as 4 and 5 months, and so, in this case, they would come out and many of these individuals would question, why did you allow me to live? I would have been better off if I just had died, and so a lot of grief and a lot of sadness, because they had an acute awareness around their loss of functioning. And oftentimes, their family would have the same kind of complicated bereavement process going on, where they were, experiencing the loss alongside the individual. Because there'd be this complicated picture too, where sometimes the individual would be able to function, but in limited capacity, and so it's like, was it that they were confabulating, or could they really not do some of these things that one day they could do, the next day they couldn't? So you have these gaps in their ability to function, which could be very confusing to families, and so there was a high degree of frustration that not only the individual would experience, but the family member would experience. and a lot of sadness associated to that, and grieving for the person that they lost, and for the individual grieving for the person that they had been prior to this happening. And so some of the other things that, define trauma is this sense of increased arousal where the person is hypervigilant, where they feel this sense of, anything could happen at any time. So they're consistently on. And because of that, they have trouble falling asleep or staying asleep, and they might have episodes of rage or anger. And so you have this kind of impasse where there's dysregulation in terms of emotion. And as we talked about previously, they have trouble concentrating, and they're just hypervigilant all the time, and they have a startled response. And so it doesn't really matter what the form of trauma is we're talking about. These kinds of symptoms will exhibit, whether we're talking about physical trauma, so a traumatic brain injury, or we're talking about a birth trauma, where there is some type of cognitive impairment as a result of that, or we have a dementia process that's occurring, or we have, PTSD from molest or from violence or some other explanation, And so as I continued in my work, I just, continued to learn about trauma as something that shows up in many cases, no matter what the diagnosis is. I learned to look for it and to rule it out as an explanation, because it is present so often and is oftentimes overlooked. And, I've been around long enough that I have experienced misdiagnosis when clients have been referred to me that had some type of trauma. They've been labeled as either bipolar, or they've been labeled as schizophrenia, and then treated inappropriately in terms of medication or even just the approach to counseling or therapy. So you can do a great disservice to a client by not assessing properly. Just recently, I had a referral of an individual who had a near drowning incident in childhood, and they've been diagnosed with schizophrenia inappropriately, because what they really experience is a traumatic brain injury. And so you can understand all of these symptoms here that we're showing and talking about, including the impulsivity as explained through traumatic brain injury and impairment in the executive functions of the brain. So the frontal lobe is impacted as a result of that. And I've seen many veterans, unfortunately, who were tagged with schizophrenia, who are really experiencing trauma. And so early on, they went through a lot of improper treatment as a result of those misdiagnoses. And so I continue to treat veterans. I get referrals in my private practice, and sometimes I get family members. And, it's important to understand the impact of trauma in these individuals, because sometimes there can be that vicarious trauma or secondary trauma to their family members. And there can be a sense of chaos or being out of control. So sometimes people will try and self-medicate and use substances as a way to control for the trauma. And they get quite astute at that, and they prefer alcohol, for example, over the medications, because they become like street pharmacists where they know how much to use, or so they think, until they reach that gray line where they step over and it becomes an addiction. I've also seen that more recently with cannabis. In fact, many years ago, I did a study, and I was interested in looking at short-term memory functioning. And I had one group that was individuals who had sustained brain trauma, and I had another group that were, quote unquote, the subjects that were, the norm group. And within the norm group, there were a couple of individuals that had issues with substances, one with alcohol and another with marijuana. And the results were very interesting, because what I found was that the individual who struggled with marijuana in their past, they were sober at the time of the study, but they exhibited as much memory impairment as did the individuals who had sustained traumatic brain injury, who had been in a coma for 4 and 5 months. And this was at a time where the THC levels were much lower than what we're seeing in cannabis these days. And so now we didn't talk about addiction with cannabis in those days, but we are now starting to talk about that because people are exhibiting signs of withdrawal, intolerance, and such that are paramount to addiction that maybe weren't seen in earlier days with lower levels of THC. So I had that interest. The other thing that interested me quite a bit in terms of trauma and grief was the experience of shame. And so about 15 years back, I wrote a book on, called Dancing Through the Darkness, the Cognitive Treatment of Shame. And what I was looking at is how people understood shame and, differentiating shame from guilt. Guilt being perhaps you've done something wrong, and with retribution, there'll be forgiveness and you can move on, and so it's about having done something wrong and correcting for that. Whereas shame can be not that I did something wrong, but I am wrong, and that I'm, not a good person as a result of that. And so sometimes people don't understand those, kind of fine line differences, and they'll talk about their feeling guilty when really what they may be sharing with you is that they experience shame. And shame can be something, that happens as a result of trauma. And, so we really want to make sure we don't overlook that important piece, in understanding how to treat it. And we want to bring people to a place of resilience. And so sometimes people experience horrendous things, but they come out very strong. And we want to understand what makes one individual be so strong and another person continue to be re-traumatized. So we get very interested in triggers and how to treat, individuals so that they can become connected to their triggers so they know how to manage them more effectively. And to help them understand episodes of dissociation, that's not necessarily something that's so negative, because sometimes the dissociation acts as a brain buffer, and it can be protective, as a way to not feel something intensely. So we just want to know when is it problematic and that it's maybe leading them to make choices that are unhealthy, or kind of fall into situations that are unhealthy. Versus when is it happening in more of a protective way. So we want to teach them about dissociation, and we want to teach them about being able to identify their feelings and being able to identify triggers so that they learn to manage their environments, so they can either, when necessary, avoid these triggers, or be able to use a graduated exposure approach, where they can be tolerant for being in an environment or near a stimuli at a level that they can handle, and eventually, a little at a time, that exposure to it. Just to give you a clear example of this, when I was living in California and working in the VA, it was an area where we would have helicopters come over during fire season, and that would be a trigger for Vietnam Era veterans, because when they hear those choppers, it would bring them back to the jungle. Or when there was a smell of Asian food, or when the humidity was at a certain level, they would become triggered. And so giving them techniques to be able to ground themselves, whether it was deep breathing, guided imagery, mindfulness, journaling, any number of techniques in order to ground oneself, was very important to teach, so that when they were in that situation, they could become tolerant of it, and be able to still be functional. The other thing that I witnessed is that a lot of the veterans were highly functional as long as they had a purpose and they were working. But when they would go into retirement, they would re-experience the trauma, and a lot of them would start to regress. And so the stress levels would come extremely high in those periods of time until they got connected to something of meaning, like a support group, such as the PTSD groups that I used to run inside the VA. And, they would create groups outside of the group where they would support one another. And those were probably even more powerful than the groups we would run in the clinic, in all honesty. And so remarkable people, and so I've shared with you some of the different environments that I've worked in. One of the other ones that I learned a lot was working in Indian health. And there I saw intergenerational trauma that was related to substance abuse and related to molestation and rape and other very difficult situations that got normalized because they were so much a part of the culture that it was not talked about and it was just viewed as normal because it was so commonplace to have occurred. And so helping people to understand that that is not something that is an everyday occurrence in many families, and it is a traumatic event, and it does affect the way your brain functions in respect to the limbic system and how emotions are processed, and it can impact cognition and short-term memory. And so it explains why there might be gaps of loss of memory and time, or feelings that can't be labeled or understood easily. So helping people repair some of that is very meaningful work for them and for a therapist or counselor as well. And so we look at trauma in terms of the duration being more than 1 month, having clinical significance in terms of social, occupational, and other areas of functioning. I think where we used to do another great disservice is that we used to think if the symptoms didn't show up in a reasonable amount of time, meaning within like the 6 months after the event occurred, then it couldn't be labeled as post-traumatic stress. We have come to understand through the work with veterans mostly, and now with molest survivors and other folks, that sometimes the symptoms come out much later. For example, when a person's feeling safe, that they can express those emotions that they're feeling, or they're far enough away from the event or the situation that the brain now feels it is time to express it. So again, we had very limited information about understanding trauma if we were going to look at it in this short window of time of an occurrence. And so understanding trauma broadened. And we know that it's not just about war zone. We now understand it can happen for all these other reasons: domestic violence, abuse, neglect, ineffective parenting, disasters, kidnapping, exiles, tortures, traumatic brain injury, other types of accidents. We could talk about that too in terms of intervention, how quickly someone gets treatment, how long they're receiving treatment, the quality of the treatment. All of that matters in terms of intervention. Death and loss of a loved one, invasive medical procedures, all of those things can be the cause of trauma and why that might occur. So these are the factors that can affect trauma, and the outcomes and the risk factors is the proximity of the exposure, the duration of it, the frequency, support services available, the quality of the care, and length of treatment and such. And so, the more we work with it, the more we understand that when you're looking at trauma, there is also connected grief. That they do seem to go hand in hand, and then frequently, when a situation of crisis occurs, it can result in trauma based on these factors, and whether or not they are attended to in terms of intervention. So, if these things are missed, the more likely that trauma will occur. So, we want to make sure, that intervention occurs as soon as possible and to the highest quality and, degree of sustainability as is possible. So, we're understanding, trauma from a different point of view now. We have to look at these individual differences that sometimes you can't explain why someone could be resilient in the same situation where somebody else would be so traumatized. And it's biological factors, it's genetic factors, it's psychological, emotional, and so when you look at it more from a holistic perspective, you get a better understanding of trauma all around. The perception of the event and how they define it, their development. We know there's certain vulnerabilities in terms of brain function. We know that, things like substance use can make people more vulnerable. and that the symptoms don't always show up immediately, and that oftentimes people are left with a sense of abandonment that will continually exhibit. And I find that that occurs in many different diagnoses. And so helping people understand abandonment and shame and triggers, are a crucial part of the work. And they're part of the toolkit that you want to have in helping people heal from trauma. And so the more we understand it and the better equipped we are to offer tools for treatment and intervention, the healthier, the people can be in working with us. So some of the hidden effects of trauma, are that it's a loss of connection to ourselves, to our bodies, to our families, to the world around us. And that's from the work of Peter Levine. People can sometimes experience subtle changes over time, but sometimes it's very dramatic changes that occur acutely. But in either way, it can impact self-esteem and reduce confidence and that sense of well-being. Feeling connected in life, can dissipate as a result of trauma, and people can have a restricted sense of feeling of freedom and a loss of vitality as a result of it. So we want to make sure we get deep enough. If we look from perhaps a cognitive behavioral approach, how we help people understand what they're thinking to what they're feeling, and how those two interrelate, and how they behave as a result of it, and ultimately getting down to what they believe. Here's an example. If I'm saying I feel worthless, or I think I'm worthless, I may feel as if I'm unimportant or insignificant in life, and I may behave in an avoidant manner as a result of that. And if that continues to be my thinking in such a negative pattern and it spirals down, I believe then that I'm worthless. And that shame becomes my identity, and it continues to re-traumatize me. So, we want to work deeply enough that we get to people's belief structures to really be able to work with that. And so in another session, maybe we'll start to talk a little bit about choice and trauma. But today, mostly, I just wanted to connect how grief and trauma are interconnected, and just think about, crisis as sometimes the trigger point, and how we're going to be able to effectively provide counseling services to work with the individuals, and to understand trauma from a different perspective that goes beyond just the limitations that are stated in the DSM. That it's a much more complex picture in some ways than even our diagnostic labels allow us to consider. And so if we treat more holistically, we get a better perspective on what may be happening with that individual or their family. I thank you for joining me, and I look forward to talking with you again. Take care now. Bye.